Hey, everybody. Welcome to Tea Talk Tuesday. Thanks for joining. I'm going to take a minute as usual to let everybody get situated and continue to log in. I noticed that my computer setting has been like 2 minutes behind my watch, behind my phone. So I'm thinking that when I was starting the stream before, I may have been starting it a little bit early. So I'm going to give another minute here. So you guys probably got used to me starting, starting late, actually starting 2 minutes late. So now I'm trying to make sure it starts on time according to my watch and my phone. So we'll see there. But I, as usual, have my drink for tonight. Last week I did coffee, and this week I'm doing coffee again. But maybe you guys have some tea in front of you. Typically I do have tea. Earlier I was drinking tea, half sweet, half unsweet. Sweet tea down here is just too sweet, and unsweet is just not tasty. So typically if I ask for half and half, it ends up pretty good. So I know a couple have joined. Please remember to go ahead and comment in the chat and let me know if you're having any tea this evening. And also, hopefully you caught last week's episode, because it was the first of this series that's on evaluation and management coding for office visits, where we're focusing in on the 99202 through 99215 codes. So we've got Christy in the house. So coffee and donuts for you. That sounds good. What kind of donuts? Are they Krispy Kreme, Dunkin', homemade donuts, anything special? I like I'm so boring with donuts. I like just like the old-fashioned donuts or regular powder. I know most people in my household love the Boston cream. Love the Boston cream donut. So if I go get a dozen, I have to get like between 4 and 6 just Boston cream, and then get the other ones mixed up. Oh, you're cheap, just store-bought. No, that's fine. Store-bought is fine. The little powder ones, the store-bought little powder ones are delicious too. So, I mean, any donut is pretty much a good donut, right? So, and Aline, you're back from Florida. Hello. Nice to see you guys back. And Aline, I know you're not a tea drinker. Don't know what you might have this evening. Madison, hey Madison, no tea yet, just dinner? Well, I guess you could have your tea and cookies after for dessert, right? And so we've got quite a few people just joining in, and we're going to get started in a second. Oh, Aline, Coca-Cola, always a good choice. Solid. I hear people say they travel to McDonald's specifically for their Coca-Cola. Something about the taste of it at McDonald's is for some reason the best. I don't know if it's some kind of setting they have between the carbonation and the syrup, but people tend to love that. So, and yeah, Madison. So, okay. So tea and cookies for dessert. And we've got Ricky back. Ricky, you are a tea drinker. Do you have any special tea for tonight? Let me know. So, just a heads up, guys, on our website, which I will pull up the banner for that. It is stalkinghorsellc.com. I did put some additional information under the Tea Talk section. So if you go to Tea Talk and then click on Tea Talk again, you will see documents in there from last week, and that would follow us through for the next for tonight and then the next Tea Talk as well. That's related to E&M, but it actually has the guidelines in there, plus the different tables. Well, it's the main table, but it's got the different CPT codes off to the left-hand side. So depending on if you're doing office visits or emergency department or hospital, it has those codes off to the left-hand side. So I did make sure to go on and share those. I thought that might be helpful. I know, like I said, our team, pretty much everybody puts ours, prints them off, puts them in a sleeve here that we have with us to reference at any time. And depending on, what I'm working on, I'll keep the sheet for E&M, whichever one is relevant to the work I'm doing. I'll keep that up. And also don't forget to join the herd. So if you haven't subscribed to the YouTube channel yet, please do so. You'll find all kinds of fun information on there. So we have this Tea Talk Tuesdays every Tuesday, 7 p.m. And then you'll also see some shorts on there that have like different videos from the code of the day, which we also share on Facebook, Instagram, and LinkedIn. And those are pretty fun and funny typically. Sometimes they're just purely educational, but we try to get some real fun ones in there. The one that was posted today was pretty fun. Of course, I love animals. So I try to find videos that have animals in them and then incorporate the code into that too, because they're always fun. I think cats and dogs are always all over videos and make for some of the best videos. And I always say like cats rule the internet for whatever reason. I know there's like tons of dog people, but there are so many funny cat videos. It's crazy. Also for this Tea Talk, if you guys remember to please hit the thumbs up for the like for this video to upvote it so that people know which videos to check out first. So the more you upvote a video, the more it gets recommended to others. Also, Ricky, what happened here? So you barely made it. No tea. Aw, okay. No tea tonight. Oh, and Aline. So yeah, you have great code of the day. You love them. Yeah, they're pretty fun. They're pretty fun. I have to admit, it does take some time to find the right video. So we look for popular videos, fun videos. We have a couple of originals also, but trying to apply a code to it, it's actually more challenging than you would think. So if you're in the field, just try to think about that. Like if you're looking at a video, can you apply a code to it? So sometimes you can, sometimes you can't, but it does make you think outside the box. So I'm going to go ahead and get going with the talk here. And thank you, Christy, for also showing your love for the code of the day. I like to know that. And I really love that you guys come on and share. You guys are creating a great community here. So we want to keep growing. But so I did also want to share that I made a couple of little modifications for our share tonight. Let me share my screen here. So this, of course, is the grid that we're working with, and this is to help level the evaluation and management services. And this is official. Nothing has changed except for the fact that we added the codes off to the left. So that's what I was referring to when I said that on our website, you'll find the document, but you'll find several of the same document, but with the codes on the left are different. So again, if you're coding for emergency department, you'll see the ED codes off to the left. If you're coding for office visit services, you'd see the office visit codes off to the left, which is the one I just shared. And then for hospital services, you'll see those inpatient and observation codes off to the left-hand side. And then also, I did go ahead and modify a little bit our examples that I used because I felt like it was taking me a long time to scroll through the example and get to the point of what we were reviewing. So I did modify it, just cut them down to get to the meat of it and put them each on one page and put that document together. Just so that it was easier for me to kind of go back and forth and share with you guys and not make that part take up as much time. And also the guidelines are on the website too. So last Tea Talk, we went over these two examples, and we talked about the very first element, which is number and complexity of problems addressed. And so we were looking at the documentation as a whole and then focusing in on the assessment and plan. Because remember, for all you providers, that assessment and plan has become the heart and soul of the documentation when it comes to leveling, evaluation, and management services. Now, history and exam need to be documented as medically appropriate. Occasionally, the HPI helps give insight into the documentation, but it is important to remember that the history of present illness, so that HPI, is really meant to be a subjective section. It's where you are, as the provider, you are asking the patient about the history of the present illness. So it's information typically that the patient is reporting in. Now, sometimes certain providers don't use it in that way, which can be a little bit challenging because in an audit scenario, you just want to make sure that it's clear. Like, if an auditor is looking at it, are they going to view that as subjective information from the patient? Are they going to understand if it's an objective piece of documentation from the provider? And so I'll give you an example of that. In one of the cases that we looked at here, in this first HPI, it stated that the patient was coming in for neuropathy, and then they talk about diabetes and vascular surgery and a visit that they had where their ultrasound showed some atherosclerosis in the legs. So this information, as it's in the history of present illness, really would appear that it's being reported to the provider by the patient. So meaning that it's subjective. So if I'm reading this and taking it at that as that value, I don't then know that these conditions are necessarily diagnosed, or, like, for example, when they mentioned that the ultrasound showed the atherosclerosis, is the patient reporting that? Did the provider look at the ultrasound? Did the provider read the report from the ultrasound? Did they have that on hand? I don't really know based on that information. So we want to be as clear as possible in that documentation so that when someone from the outside reviews it, we know exactly what's going on. So if we take this note and then we come down to the assessment and plan, the only thing that was in that assessment was the diabetes, which, again, if that HPI is current, relevant, was not a carryover or a copy and paste, then where's the neuropathy? Where's the atherosclerosis of the lower extremities? Where's the information on that? So in this case, if we just take that assessment and plan and we use that to level the visit, this provider may have actually provided a more complex visit than what they're giving themselves credit for. So I always recommend that you carry all of your diagnoses that you considered in medical decision making into your assessment, and that there was some kind of a status documented in a plan of care. So we went over this information last time, and we had determined that between the two notes, where we would have considered them to fall on our number and complexity of problems, right? And so today we're going to look at those same notes, and we're going to talk about amount and/or complexity of data to be reviewed and analyzed. So one of the key things that I always recommend to providers and coders alike that are learning and adjusting to these guidelines is you want to make sure that you're reading the fine print. And this chart has plenty of fine print in it. And it actually gets a little bit more complicated for this data element. And when these guidelines first became active in 2020, then they were modified a couple months later and then modified again in 2023. the data element always was a bit tricky because we were trying to figure out some of the little idiosyncrasies that exist in this chart. So, for example, when you're reading the fine print here, just here under this title for amount and complexity of data to be reviewed and analyzed, let me make this a little bit bigger for you. They mention each unique test, order, or document contributes to the combination of 2 or combination of 3 and category 1 below. So, right there, you're already like, okay, this is going to get a little bit complicated. What am I going to be looking at here? What do they mean by each unique test or order or document? So let's kind of take a look at the categories that exist in that column there. So I'm going to zoom out a little bit for a second and then zoom back in. So if we look at the first row where we would have information, it says not applicable because that would be for a nurse visit. Then underneath that, again, for amount and complexity of data, we have minimal or none. So for a level 2, whether it be new patient or established, that would be minimal or no data. And I don't really know yet, if we're only looking at this, what do they mean by minimal? So then if I look down one more, the data would be limited. And limited would qualify for a level 3. So again, reading the fine print must meet the requirements of at least one of the 2 categories. So I can see that there's a category here and there's a category here. So we must meet the requirements of at least one of these 2 categories. So bear with me here. If you have questions, please don't forget to put them in the comments. I can answer your questions, pull them up on the screen there. I do know that this element gets to be a little bit cumbersome and tricky, so feel free to comment there. So let me go back here now. So in the first category, it says any combination of 2 from the following. And so let me highlight this in a little bit of a different color so we don't get tricked here. So for category 1, we need any combination of 2 from the following. So review of prior external notes from each unique source, or review of the results of each unique test, or ordering of each unique test. So that word unique, right? Unique, and each. So each unique, each unique, each unique, each unique. So that keeps coming up over and over and over and over again. So what do they mean by each unique test or each unique source? So we're going to be able to find that information within the guidelines of our E&M section. So I shared that again on our website, and I'm going to bring it up here. And the guidelines detailed the data elements starting on page 16. So starting on page 16, you'll see the information for that data element. And I had highlighted some information for us. So unique is defined as, so it says a unique test is defined by the CPT code set. So what they mean there is that if there's a specific test that's being ordered, it's based off of CPT. So one of the trickiest things there is with laboratory. So labs can be ordered as a panel or individual labs can be ordered. So, for example, a doctor can order a lipid panel, or they can focus in on one specific test that they're looking for, right? But it depends on how many codes are available with what they're ordering. So each unique CPT, so if they put in several orders, each lab that has its individual CPT code would count as something separate. So that's really important to think about. Also, each test that's being ordered. So if there's an X-ray and an MRI, or an X-ray and an ultrasound, those are different tests. They're represented by different CPT codes. So those would count, each individually would count toward that data. So if we look at the category 1 here, if they ordered a CBC and CMP, there are 2 unique tests. So even though we're talking about one bullet, because they've ordered 2 unique tests, we meet the criteria for combination of 2 from that. The same thing if they ordered, let's say, a CBC and an X-ray. We would then get still credit for that. Let's say that the patient was coming in and they had a test performed by another provider. So let's use that example that we looked at and say that they had an ultrasound performed from an outside provider, and they brought that ultrasound result in with them. And then they also had labs from the hospital that they brought in, and that was reviewed from an external source. Then we would actually have multiples there. Now, one of the key things is in this section that we need to concern ourselves with is that a provider gets credit when tests are ordered. So when they're ordered, they're presumed to be analyzed when the results are reported. So therefore, when they are ordered during an encounter, they are counted in that encounter. So tests that are ordered outside of an encounter may be counted in the encounter in which they are analyzed. So the reason that basically sounds like a bunch of gibberish, right? Like, what are they saying here? So what they're saying is that as a provider, if I go in today and my doctor says, I'm ordering these 3 labs for you, during that visit where my provider's ordering those 3 labs, because when they're being ordered, they're presumed to be reviewed when the results come in, the provider gets credit for ordering those 3 labs during that encounter. However, if I come back in for a follow-up visit and those same 3 labs are reviewed, the provider does not get credit at that time because credit was given at the time of the order. So they don't get credit again for reviewing them. They're presumed to be reviewed when those results are available. However, if it was a different provider from outside of that group practice that ordered tests, so they came from somewhere outside, not part of that group, then they would be able to be counted. Or if the tests were ordered outside of a visit, sometimes that happens, they then could be counted during a review. That does get pretty tricky because keeping track of that, it need to be clear in the documentation how that works, or where that information came from. So that's like a pro tip for providers for their E&M in that data element is if you are reviewing something that comes from an outside entity, making it clear that it came from outside of the group is super important to ensure that you're getting credit in that data element. I can just say that for most specialties, the data element doesn't typically drive the level of visit. It can. It doesn't typically. So it's also not something that anyone should lose a bunch of sleep over or freak out about. And so the same concept applies for the imaging tests. So if that is performed from an outside provider and then it's being reviewed internally, it can be counted. If it's being ordered during the visit and it will be completed later at an outside facility, then you can get credit during the order. The key thing to remember with certain tests, the most common would be like x-rays, is if your practice performs that in-house and you bill separately for it, you are not allowed to give yourself credit for that data in the E&M section, because if you're separately reporting the x-ray and you're reporting the global code, then you are being compensated already for performing it and for the interpretation of it. And that also is noted here in the guidelines. So any service for which the professional component is separately reported by the physician or other qualified healthcare professional, reporting the E&M service is not counted as a data element ordered, reviewed, analyzed, or independently interpreted for the purposes of determining the level of medical decision making. So they would consider that double dipping, because if you're being, again, compensated for such like something like the x-ray where you're performing it in-house, you're performing the interpretation, you're getting paid for the whole service, they're not going to give you credit also in your data element because you are being compensated separately for that. And so let's see, we've got a question here. So Aline says, so if a doctor didn't order but reviews them, they get credit for reading them. So if a doctor reviews a x-ray, let's use an x-ray still as an example, from an outside entity, so someone outside of the group, because remember that you could go to a doctor's office where there's multiple doctors that are a part of that group and you just see one particular one. It would have to be outside of that group where they ordered it. If the results are brought in, so they receive the record and then they review it, they can get credit. And then that actually breaks down a little bit further as to whether they did an independent interpretation or not. So we'll talk about that in a second, because that's going to be in our next level down on the data. But if those results are brought in from the outside, then they can get data credit for it. Okay, you got it. Great. Thanks for that question. That's a common question. And it can get confusing for the providers also. So there is an actual, you guys, that there's always exceptions to rules, right? So there is an exception to that rule. If the office performs a test that's a result only, so usually that would happen in like the primary care setting, where maybe they do like a rapid strep test or a flu test, because all it is getting a result that can be counted toward data, because there's no separate interpretation for it. So the payment for that is it's different. So in the services where there's an independent interpretation that's required, the payment for that is higher and more complex and includes more versus just those result only tests. There's always exceptions. Yes, I saw that, Aline. Yeah. And, they can't make it too simple, right? It'd just be too easy then. You got to make it a little complicated. So overall, those are, in my opinion, the most complicated parts about the data element. So let's go back to our table here. So if we wanted to take a look at category 2, that would be, it says assessments requiring an independent historian or independent historians. Um, so an independent historian, this one gets tricky for providers as well. An independent historian is someone who the provider has to obtain additional information from in regard to the patient to get an adequate history. Now, that doesn't mean that a spouse who comes with you to complain about you counts automatically as an independent historian. So one of the common examples is with like like sleep apnea was one that came up a lot where a spouse may go and say, "Oh, so and so snores so much and this and that." But it may just be information that's volunteered. It may not be information that was medically necessary for the provider to actually obtain from someone in order to make a decision. So the independent historian has to be something that's medically necessary also. Typically, the most common instances where it's required is in patients that have memory issues, dementia, Alzheimer's. They're just not reliable historians. And so, of course, the documentation would need to explain that also, because we need to know, we need to see that medical necessity for the independent historian being required. In pediatrics, it's the most common, right? Because patients are too young. So that's one thing that's presumed. We would know that the parent would need to be giving some form of history there for the patient. That makes sense. But again, in other instances, it doesn't count if it's just information that's just kind of volunteered. It needs to be something that's medically necessary. So the provider needs to have a reason, to be able to obtain that from someone else. And it could be it doesn't necessarily have to be from a spouse, could be from from a caregiver, from a social worker, a counselor, someone at a school, for example, a teacher. So there could be an independent historian that you haven't necessarily thought about. So it does require some thinking outside of the box. And so for the providers, again, that's something that's interesting and maybe something that you've done but not documented well. So that's also an opportunity for improvement there too in our documentation. So in order for us to meet that level 3, let me just scoot this over. We would either need to have 2 unique items from this list or an independent historian that's medically necessary documented. So, you would be surprised actually at how many fall into this level 3 category. And so anything that's done that doesn't meet this mark would end up being minimal. So an example of that may be maybe they just order one x-ray, right? So if they just ordered an x-ray, that would be minimal or none because it's just one. So it would be minimal, right? Or maybe there's no data. Maybe there isn't anything that's ordered or reviewed or, no independent historian, no external notes. Then it's none. And that's fine. Again, it takes 2 of these elements to actually select the level of service. So just because there's no data, that's not a problem per se. It's just, how that visit went. It's just the complexity of that visit, that medical decision making. So we're going to take a look at the next category here, which would be, or the level at least, it would be moderate. So for moderate, again, let's read this fine print. Must meet the requirements of at least 1 out of 3 categories. So now we have 3 categories listed. I'm going to change the colors here so it's easier to see. Okay, so category 1 has combination of 3 from the following. So limited had 2 from the following. This has 3 from the following. And now, interestingly, you may see that independent historian is now rolled up under category 1. So under limited, it was its own category. Now it's rolled up under category 1. So you may have, though, you again, you would be surprised how many visits they order, like 3 labs that are 3 separate CPTs, 3 separate labs. And that in itself qualify, qualifies for that moderate because it's 3 unique tests. Or maybe they do 2 labs and an ultrasound, or 2 labs and an MRI, or maybe they review notes from an external source and the provider documents that well. That's another thing that typically is missing from provider documentation, some kind of work that they do that adds to the complexity that oftentimes they forget to document. That, reviewed notes from pulmonologist found that, patients' COPD is, now requiring, multiple meds, whatever the situation is. But many times providers just don't think to document that there. They interpret the information, they're thinking about it, they're using it in the decision making, but it doesn't necessarily come natural for them to automatically include it in the documentation. So again, the reason in going over this with your providers, and for us doing this on T-Talk, is understanding what your documentation is being compared to, what's being used, helps you to document better, helps with that documentation improvement. Once you understand what's needed, or what they're looking for, totally can help, right? Can totally change the picture, because as a provider, you may know that complexity in your head. Like, gosh, this was definitely a level 4 because I did all of this work. But if it's not showing in the documentation, if we can't see it and utilize this to substantiate it, right, to qualify it, then your service may be downcoded. So we want to make sure that you are being compensated for that complexity of care that you're providing. So let's take a look. So category 2 is independent interpretation of tests. So Aline, to get back to your comment, so we know that there is a couple different ways that imaging is looked at. And honestly, it seems to be different among specialties as well. So a doctor can take a report that's provided to them from a radiology office, right? So like, I don't know, maybe you go to Rose Radiology or something and you had an MRI. So a provider can take that written report of the MRI and review what the findings were based on the radiologist, what they say they saw in that MRI, right? They can do that. And that would just be the reviewing the result of a unique test, right? But there's a difference between doing that versus when they say, hey, when you come for your visit, we need you to bring the disc with you. We need the actual images. So then sometimes the doctor will take that disc, load it up, and look at the image itself. And then they will make a determination. So they will make an interpretation based on what they see. So that's an independent interpretation when they look at that imaging themselves and document that. Again, they need to be documenting that they reviewed the imaging and they found, X, Y, and Z. So I reviewed the imaging and found that, the L5S1 is herniated, just for example. So we need to see that they looked at the image independently and had their own interpretation. That is different from, again, just reviewing the report that was provided. So if they did document that they looked at that imaging and what their interpretation is, that's when they would qualify for that independent interpretation of tests. So this in itself, if that's all they did, that automatically qualifies them for moderate level of data. So that's pretty good. But again, that same rule still applies that if that test is performed by your group and you report that CPT code where you're getting paid for the interpretation and the performance of it, you are then not allowed to get credit on the evaluation and management side for it. So most places don't have MRI machines like in their office, right? But again, X-rays are more common. So orthopedics is a big one. So there's some orthopedic practices that they may say, hey, you were seen in the emergency room, bring your images and the reports. If they review the images that were performed elsewhere and they make an independent interpretation and document it, they can get credit for that. However, if they say, we have an X-ray machine here, we're giving you the X-ray, and then they bill for that X-ray separately, they will not get credit for the independent interpretation because they are billing for performing that X-ray, which includes that interpretation, typically speaking. Now, if they're only billing for the technical component, that's a different story, but that's a whole nother topic. I doubt there's anybody in here tonight that has a question about that. But if you do, please post, or anybody watching after the fact, feel free to comment the question and we'll get back to you on it. But generally speaking, that's how it works. There's one more category under moderate. So let's take a look. So category 3 is discussion of management or test interpretation. So discussion of management or test interpretation with external physician or other qualified healthcare professional or appropriate source, not separately reported. So this one is interesting. Some providers misinterpret this to mean like if they supply their notes to another provider, that counts. That is not what this is. This has nothing to do with like continuity of care and keeping other providers informed. This has to do with one provider needing to call another and speak to them specifically about something to do with the patient. So it could be related to imaging. So it could be that physician has to call, they decide to call the radiologist, and I've actually witnessed that happen before, where they have a differing opinion when they're reviewing the imaging. They need to discuss the case with the radiologist. It happens a lot in certain surgical practices like general surgery, vascular surgery. It can happen. But the key here is that the communication and the exchange has to be direct. So it can't be someone from their staff is calling another staff member or a trainee to ask a question. It has to be a direct communication between those providers. Oddly, the notes state, let me show you something weird here. They do state that the discussion does not need to be on the date of the encounter, but it's counted only once and only when it's used in the decision making of the encounter. I say that that's really odd because for that to get documented in the for that to get documented and then held off on for another day for then a discussion to happen to then go back and be documented, like we don't know if the discussion happened unless they document it. So we need to see that actual discussion in the note, something about it occurring, right? Doesn't have to be like a recording of the discussion, but there needs to be documentation that contact was made with that other professional and the subject that was discussed and how it affects the decision making needs to be clear there. So I don't ever typically see that happening. Like I don't see something being held off on from billing and coding or even signing a note. Sometimes that communication will go in after the fact. But if it does happen after the encounter, it typically is missed. And I mean, that's unfortunate, but that's typically what happens, just to be completely honest. So let's see. there's a couple of questions here. So let's see, Elaine. So if this group orders a test, which is a large group of different doctors, you wouldn't be able to bill, correct? So when there's questions like that are specific to larger groups, it gets super tricky. And so that's where you would have to ask a lot of questions of that group, how things are set up, as far as payment is concerned, if there's different tax IDs, if there different specialties. So there's a few caveats to that. So that's like not an exact question that I could answer off the top, but if it's a large group, so even if it's like they're a large primary care group and they're all the same specialty and they're under the same tax ID and everything, then even if it's another doctor in that group, they would not be able to get credit for it on the E&M side if they've billed for it separately, because then that group is already being compensated for that test. So hopefully that answered your question. Ricky, so can it be an email? Great question. So I kind of mentioned this. They say sending chart notes or written exchanges that are within progress notes do not qualify as interactive exchange. But it does say, so again, that's within progress notes. So that's again, like if they're sending their progress note to the other provider, that makes sense. That doesn't qualify. That's just keeping them up to date. But it may be asynchronous. So it does not need to be in person, but it must be initiated and completed within a short period of time. So within a day or two. So the answer to that then would be yes. And so I see, Aline, you said it's a network of doctors. I'm assuming that, just in general conversation, if it's just a large group, then, again, ordinarily, no, they're not going to be able to get credit on the E&M, but they're going to want to they would want to bill for that service separately anyway, because they're going to be compensated for it. And again, on the E&M side, a lot of times the data element isn't really the driving factor there. So, and those tests are just one small part of the data. So I try to tell providers to, like, don't get too frustrated, don't get too hung up on what your group is missing out on, because I know that there's a lot of thought that goes behind it, and some of it I completely understand that it doesn't necessarily seem to be fair that that a provider, let's take those labs for example, that you get credit only at the order and then not when you review them. It does seem odd. Like, you had to make the decision to order them, that it was medically necessary to do that. So you had to use that decision making there. And then when you're reviewing them and you're interpreting the results, you then have to make a decision based off of those results. So I can understand how that doesn't seem, fair, but unfortunately, I don't make the rules. Well, actually, that's probably fortunate, because, oh gosh, that that would drive me crazy having to make those kinds of decisions. But right now, that's how the guidelines are set up, that you get credit at that order. And again, if it's something that's separately billable that has an independent interpretation component, you're not going to get credit for it if you bill it separately. You don't need E&M credit, because they consider that, again, double dipping. So let me hang on a second here. I'll double check for questions again in a second, and let's move on to the next category here. So moderate seems to be pretty, again, straightforward. Then if we look at extensive, which would be our level 5s, let me just highlight, we have to meet requirements of 2 out of 3 categories. So we only had to meet requirements for 1 before, and now we're having to meet the requirements of at least 2 of the categories. So let me highlight these. All right, so now we would need 2 out of these 3 categories in order for it to be extensive. And to be honest, that's not very often that it happens. It does not happen very often, um, for, there to be 2 out of those 3. In instances where it does happen, typically it's an independent interpretation, so patient maybe had, um, an MRI somewhere, and the provider looks at the imaging, documents their own independent interpretation of that, and then um, they also order some labs, or they review notes from an external source plus order labs, or have an independent historian, something like that. But usually it's between labs, record review, and independent interpretation that pushes data to be more extensive in nature. And oh yeah, Lindsay, so level 5 data seems to be so hard to achieve. It is. It doesn't happen often. And so yeah, Aline, so you agree. It's true. It doesn't happen too often. That's why I say also it takes 2 out of these 3 to get any particular level of visit. It's not very often that that occurs. I'm going to go ahead and pull up our examples now to see if we can dig through to look for data. So let's see what we come up with. So this is our first example. So this patient presented for problems with neuropathy. So they were seen before for diabetes. The A1C looks high, 8.4. Patients gained weight. He's on Lantus and Victoza. He's had high numbers. He went to an appointment with vascular surgery, and his ultrasound showed some atherosclerosis in his legs. So again, this is unclear how they got this information. Is the patient reporting this to the provider? Is the patient saying my ultrasound showed this? Did the provider read the documentation from the vascular surgeon's office? Did they provide that? So are they reading external notes? Did they look at the imaging themselves? Like, I don't have any information there. That's very unclear. So I don't think I can officially count that. I don't have any background information on that. And the HPI is typically a subjective area. So this could just be patient reported. I'm not sure. So he comments that he still has pain in his feet and that the pain had started around when he was diagnosed with diabetes. So then when we come down to the assessment, we see diabetes, and it's very non-specific. So continue using your medications as prescribed. Bring your CGM reader next time so we can ensure it's working. And they ordered a lipid profile, vitamin D, and A1C. So out of these things, if we think about data, we do know that they ordered a lipid profile, vitamin D, and an A1C. So we do know that they have 3 labs. I'm not going to count, I would not know where to count that ultrasound information. I don't know for sure if they reviewed any external notes. I don't know if they looked at the imaging. I don't know if that's an independent interpretation. It appears that it's reported information from the patient. So I can't credit the provider with that. But I do know that there were those 3 labs that were ordered. So because they're putting the order in, we can give them credit at the time of the order. So if you guys have your chart in front of you, feel free to comment if you'd like, but let's go ahead and take a look to see where that would fall. So we know it's not minimal because we had a couple of things there. So this isn't a combination of 2 from the following. And we have unique tests that they ordered, but we have more than 2. So if I look down into this next category for moderate, we need any combination of 3 from the following, ordering of each unique test. We have 3 of those. So this does meet the requirement for moderate data. So that wasn't hard. Like, if you think about this documentation and how small it is, it really wasn't hard to meet that requirement with how little they documented. Now, there's a lot of room for improvement in this documentation, just aside from us talking about the ultrasound. The neuropathy has not been brought down into the assessment. There is an automatic presumed causal relationship between diabetes and neuropathy, and that would change the diabetic code. Also, that atherosclerosis is not mentioned. So this would be something that the provider could really improve upon. They would want to really make sure that all of the conditions that impacted care during that visit were documented in their assessment and plan, so that we clearly could see what's going on with this patient, what the picture is. I mean, and chances are, like, why'd they order the lipid profile? Could be do something with the diabetes, but it also could be because of atherosclerosis, right? So we would really want this provider to improve their documentation in that way to ensure that they actually get credit for the complexity of care that they're providing to that patient. It's really not a full assessment for this visit. This note kind of looks like this assessment's just incomplete, but that's what we've got. So let's go ahead and take a look at the second example. So in this example, it's a 37-year-old, heart failure, doing well, still under care, denies chest pain, endorses mild shortness of breath, suspects it will improve while walking, taking furosemide, hasn't noticed any edema. We've got the exam here. So the assessment and plan, we had heart failure with reduced ejection fraction, and the plan is to decrease one of their medications due to getting low BP, continue another medication, restart a medication, and follow up is scheduled. And then they also have cardiomyopathy documented and a plan for a CBC with differential platelets, CMP, A1C, lipid panel, and TSH. So we have like at least 5 labs here. I don't see any other documentation that is pushing me to think that anything else was reviewed or documented. So again, we've got a bunch of labs. So if we look down, we had more than 3, so we know we at least meet moderate. But can we get to extensive? We would have to have 2 out of these 3 categories. We know we have this category met because we have multiple labs here greater than 3 or more, right? But we don't see any documentation for an independent interpretation or any discussion of management or test interpretation there. So in this example, also, we would be at moderate. So both cases really were not like super complicated in that plan, but you could see how quickly those individual orders or individual tests can add up. And that's pretty common. Those scenarios are pretty common with that data element, I would say, at least in my experience over 20-something years. So that's pretty common. I think that, again, in both instances, there's always a little bit of room for improvement there. I would have been interested, again, in that first case, knowing more about the ultrasound and seeing those other conditions be brought down into the assessment. And then in the second one is a little more complete in the second case. But I'm curious to see if, depending on this specialty, what were notes? Did they review anything from cardiology, from a separate, specialty or separate group? What did that look like? What did that show? So I'd be really curious to know that as well. So looking at it from the coder's perspective and auditor versus the provider, you can completely get a different picture. And a lot of times, again, that's where there's just like a disconnect between the provider, like what service they know they provided, and that complexity that they know that they provided to the patient, but is that represented in the documentation? And can we see that in our guidelines? Are we able to translate that information, push it over to the guidelines, and have it supported? Because at the end of the day, that's what their, contracts state to use and what they're being pushed up against. So we need to make sure that it qualifies based on those guidelines. So that kind of wraps up that data element. There was a lot to unpack there, but I actually think we did it in a pretty good amount of time. I think we made it in like just under the hour. So please feel free to make some more comments, you guys. If there's something that I didn't get a chance to answer, I will try to follow it up on next Tuesday, because I'll take a look back at the comments, because I may have missed a few just from like flipping back and forth. So if I did, forgive me there, but I'll take a look and see if I can get those answered next Tuesday if I did miss something. I know that some people tend to view after. So again, feel free to comment even after the fact. If we're not live, we can still answer that question in the next live. And please remember to join the herd. So like and subscribe to us on YouTube. And you can follow us also on social media, Facebook, Instagram, LinkedIn. Feel free to join us every Tuesday. One thing that people don't realize is that during these lives, I'm the one who's live. You are not. I get that question a lot from people who like are tending to watch it after. They're like, well, I didn't want to be on camera. You guys are not on camera. It's just me. So your comments will show up. If you want to be on camera for some reason, I surely can have some guest speakers join, but I'd have to send you a link in order for you to be on camera. So don't worry. You're not on camera unless you want to be. So again, leave your comments, your questions. Next time, we're going to talk about that final element, the risk element, and we're going to tie the whole thing together and be able to level those notes. So I'm pretty excited about that. I will see you guys next Tuesday. Thank you, Christy. Thank you for the compliment. Appreciate you guys and building this community. And don't forget to share the word with your friends. We want to keep building this community so it's open to all, whether you're in school, if you're a provider, even if you're a resident or in school for coding, feel free to join. The more the merrier. And we want to build this community to benefit all of us. So thank you guys again. I, again, appreciate your time and look forward to next week's Tea Talk. So have a great rest of your night. See you later.